Okay, last one in this series, chapter 48, we're going to talk about the intestines. So now we move beyond esophagus and stomach, and now we're going to skip the small intestines. There's not really malignancies or anything awful that can occur in the small intestines except for adhesions and irritable bowel. So we'll talk about those, but so what I want you to know from this chapter, inflammatory bowel, irritable bowel, ileostomies, colostomies, and wound ostomy nurses. A lot of you may end up going into becoming a wound ostomy nurse because those are in high demand. And those nurses are super good at being able to deal with wounds and ostomies and stuff like that. So I told you a little bit about constipation earlier, and do a good assessment for why the constipation is occurring. Don't just automatically assume somebody's dehydrated. Kind of look through there. There are some risk factors that are more common in the elderly down in chart 48.1. The thing that I want you to focus on with somebody who's constipated is the medical management, because there are a ton of things that a person can do. And it can be as simple as increasing your fluid so you're not dehydrated, increasing fiber so the stool bulkens up, increasing agents that increase peristalsis, adding lubrication to the GI tract, and like with mineral oils and things like that, adding stimulants that will actually stimulate the colon to move, stool softeners so it's easier to get the stool out. So there's a million different things. If your patient has had surgery, they're at high risk. Any GI surgery will tend to decrease peristalsis, at least for a time. A reduction in peristalsis is called an ileus. So your GI tract is supposed to, kind of do this milking thing. It moves food down. Well, when the GI tract gets irritated or disrupted, like in surgery, that tends to stop. So then the food or the waste products that are coming down here get to this area which wants to be moved along, like on the conveyor belt, and all of a sudden this part of the conveyor belt is shut down. So that can cause a bowel obstruction related to an ileus, because the food gets right there and just kind of sticks. So that's what that's called. Diarrhea, same thing. The thing that we worry about diarrhea, opposite of constipation, is electrolyte loss, because there's a lot of water and electrolytes are absorbed in the large intestine. The main purpose of the large intestine is to reabsorb water and electrolytes. So this also becomes something you need to be aware of depending on where the ostomy is put in. And I'm going to tell you about that a little bit later when we talk about ostomies. Some of the things I do want you to know a little bit about how to manage diarrhea, because a lot of the disorders like irritable bowel syndrome, Crohn's disease and stuff, these people have chronic diarrhea. So there are certain medications, certain antibiotics, anti-inflammatories, anti-diarrheals, that can reduce the severity of the diarrhea, and they can treat the underlying disease. In most cases, like loperamide is usually the medication of choice, because it has fewer side effects than some of the other antidiarrheals have more significant side effects, and that's one of the opiate-related diarrhea, antidiarrheal. So that's a good one. It's got the opiate component to it. So fecal incontinence. Just because your patient is getting elderly, they should not automatically have fecal incontinence. So they usually need to have a workup. What's the problem? Is there reduction in sensation? Is there a sphincter problem? So just because somebody is aging does not mean they automatically are going to be incontinent of feces. Okay, so now I want to talk a little bit about irritable bowel syndrome. Irritable bowel syndrome is basically an inflammation of the colon, and it leads to abdominal pain, bloating, a lot of diarrhea. It's a chronic problem, and it tends to get better and then get worse and get better and get worse. Sometimes it's worse with stress, dehydration, other infections, things like that can lead to increases in irritable bowel, and malabsorption problems. These people tend to be really thin. It is a awful lifestyle thing because of such frequent diarrhea. Sometimes they'll go 6, 8, 9, 12 times a day. They have to run to the bathroom and have diarrhea. Well, as you can imagine, this becomes very problematic if they're going to try to go out in public and try to go to a party or something. And, you know, every couple minutes they're running to the bathroom for diarrhea. So they tend to get isolated. The perineal area gets very excoriated, so another nursing thing that we watch for in our patients that have irritable bowel is, you know, good perineal area cleansing, good diet, good nutrition, foods that are going to cause less bloating. Table 48.2 is a pretty good indication of who might be at higher risk for developing some of these disorders that lead to malabsorption. So the let me just see if they have lumped in. Oh no, they don't. They don't. Okay. So they have separated out Crohn's disease with inflammatory bowel disease. So sometimes you will hear people lumping those together, the irritable bowel syndrome and inflammatory bowel disease. Those are very interchangeable. For some reason your text has them separated by several pages. Irritable bowel is over on page 1292 and inflammatory bowel is over on 1301. But they're really similar because they're a group of chronic disorders. Crohn's disease and ulcerative colitis kind of make up the inflammatory bowel disease, and irritable bowel is just sort of a generic term for all of that. I want to talk a little bit about appendicitis because it's fairly common. You'll see it a lot, especially if you're working in an emergency department, the emergency room. An appendicitis is, look at the bottom of page 1295 in figure 48.3. You see how on the right side of the body, this is your ascending colon. This goes across to your transverse colon, down the descending colon, and out into the rectum and then the anus. But right at when the ascending colon starts, there's this little finger-like projection called an appendix. Nobody knows why you have an appendix. Nobody knows the function of the appendix. However, that appendix tends to, in some people, get irritated and infected, and it needs to be removed surgically. So if somebody comes in, and this tends to happen in fairly young people, like they're anywhere between 15 and 30, they come in, they will have a fever, nausea, and they'll be complaining of abdominal pain. A classic sign is if you push right here, and they'll have that rebound tenderness. Once somebody in the healthcare field has documented that and charted it, don't keep doing that because you have the risk of one, rupturing the appendix, and you know it's already there, and it's just going to annoy and hurt the patient. So once it's already been documented, you don't need to keep assessing for that. You should, however, get a white blood cell count, find out if those white blood cell counts are high. Which is another indication that they have appendicitis, and then that appendix has to be removed surgically. And because what you try to do is you want to get that appendix out before it perforates and ruptures into the peritoneum, because now you've got peritonitis, which is a much more significant problem than just appendicitis. So once you diagnose your patient with appendicitis, you get them scheduled for surgery and remove that before the infection bursts through the appendix and into the peritoneum. And from the time of diagnosis to the time of rupturing is usually about 24 hours, so you don't have a whole lot of time to make a diagnosis and then get that appendix out surgically. So keep that in mind. Diverticulitis, we already kind of talked about, a little sac-like thing. Oftentimes that can be just treated with antibiotics, but if it's persistent, then they have to go in and take out that piece of colon that has the diverticulum in it, so the food and stuff can't get stuck in the diverticulum. Oh, and there's a picture of how they can remove it if it's bad enough. Now, one thing I do, let me see. Is this where they're going to... No, all right, I'll tell you about that in a second. Peritonitis, I'm on page 1299 now. Peritonitis is just when fecal contents or stomach contents are in the peritoneum, and the peritoneum is the space in between all the visceral organs in the abdomen, and that needs to be treated with strong antibiotics. Inflammatory disease, like I already kind of alluded to this, your two choices there are Crohn's and inflammatory bowel disease. Those are chronic diseases. There is no cure. There is some treatment for it, but no cure. In some cases, if it's really significant, they will go in and remove the colon, but they leave that for the very, very end, because usually these disorders show up in young people. They'll start showing up in adolescence or early adulthood. So nobody in that age group, nobody ever wants to walk around with a colostomy. So they usually try to do conservative management before they have to actually do surgery to remove part of the colon. So a really good table is on 48.4, where there's a comparison of Crohn's disease versus ulcerative colitis. In the general population, those are both lumped under like inflammatory bowel disease, and because they're very, very similar. So you kind of read through that. But what I really wanted you to know next is how some of these diseases and disorders of the colon are repaired, because they're a chronic condition, and like I said, we've got some ways to reduce symptoms, but we don't have a way to cure it. So when the colon gets so severely damaged that they have to remove a part of it, there's several ways they can do it surgically. Sometimes they can make an ileostomy, where they will take a piece of the ileum and they will put it up through the skin, and then the waste goes into there, and they'll just let the colon rest so that no more food can go through there. And then sometimes they'll try to reanastomose those two pieces, so the patient may have to have an ileostomy for 6 months or so to let the colon, 6 to 8 weeks, let the colon rest, and then they can reanastomose that. Sometimes they can do, they can make a pouch, and that there's a picture of that where they make like ileal pouches. Sometimes they can do an anal anastomosis, so that instead of it coming out through a bag, it comes out through the anus, so they can defecate like a person who doesn't have a colostomy. The thing with colostomies or ileostomies, the first thing is you've got to start preparing the patient, because it is very difficult to wrap your head around the fact that all of a sudden my normal elimination patterns through my rectum are now going to be through my stomach and into a bag. A lot of people who have weak stomachs or they have, it's very difficult for their self-image. Very difficult for some lay people who have not, you don't have to, normally you don't have to look at your stool. You sit down on a toilet, you defecate, you flush it, and that's the end of that. Well, now people who have ostomies, they have bags, and they walk around and the stool is going into the bag. Well, that's really hard to deal with. So you as a nurse, the emotional component of somebody having to have an ostomy is huge. Where the ostomy goes is very, very important. Many surgeons will not think this through, but it really matters, because if somebody has to have a colostomy in their transverse colon, well, that's right where your belt line is. So if you've got a big bag right there, now all of a sudden you can't wear jeans, you can't put belts on. So oftentimes the wound ostomy nurse will come in preoperatively, have the patient stand up, watch them move, see what kind of clothing they wear, and then mark a place that might be a little bit more convenient for the patient to have an ostomy. Because the surgeon, once that colon is cut, they can pull it up wherever through the skin. It doesn't have to be exactly where it was. They can move it around and put it in a spot that's actually more convenient for the patient. But this is a nursing thing, because sometimes surgeons don't think that kind of stuff through. Sexual counseling is really important, because obviously, when you're engaged in sexual intimacy with somebody, it's usually, face to face. Well, now you've got this big bag there. So it's really helpful to bring the partner in and start talking about some of these issues. How are you going to address this issue with this bag? And is the partner okay? And you really, post-operatively, want to work with a patient so they can start doing their own ostomy care. And basically you just tell them it's like perineal care. It's just actually more convenient because now you can see it. It's easier to get to than where your anus is. And so you just want to keep it nice and clean and dry. There's lots of stoma products now that, the plast or the sticky part attaches to the skin right over the opening, the ostomy. And usually it's like a little Tupperware cap, and then you put the bag goes right over it, and then the feces will go into the bag, and then they just need to be taught how to change the bag or empty the bag. And they can do that anywhere along the GI tract. The thing that you have to keep in mind is the placement of the ostomy will have a lot to do with the patient's fluid and electrolyte status. And on page 1313 shows you kind of how to change that appliance. I think you guys have all done that in the skills lab, but if not, let me know. I'll go over it in class. I thought there was somewhere in your book that talked about ostomy placements. Oh yeah, go over to page 1322. These are all different places where ostomies can be placed. The lower in the large intestinal tract, the better. Because, like I said before, water and electrolytes are absorbed through that GI tract. So the lower it is, the closer to the rectum, the more fluid and electrolytes the patient will keep in their body. The higher it is, like over near the transverse or ascending colon, the less water and electrolytes the patient will have, and the more at risk they are for fluid and electrolyte problems, because you've circumvented the part of the colon, and that's what the colon is designed to do. Also, while we're over here, figure 4811 shows you a pretty good example of what a colostomy appliance sort of looks like. I did want to talk a little bit about bowel obstructions. The thing with small bowels is they are prone to obstruction because they're really slippery. And any kind of scar tissue will cause bands to come down on them, and they're much softer than the large intestine is. They can get ileuses, they can twist, and they can get something called intussusception. Intussusception is much more common in children, so I'm not going to go into it. You'll probably hear about it in pediatrics, but it can lead to a very significant life-threatening obstruction in the small intestine. I do want you to be familiar with what a small bowel obstruction is, what can cause it, and how to fix it. Sometimes if it's minor enough, they can just rest the bowel, put the patient on NPO for a while so it slows down peristalsis, slows down food and gas going through there. Other times, if it's so significant, like if it's adhesions, sometimes they have to go in and actually remove those adhesions. The risk is they probably had surgery in the first place, which surgery leads to adhesion. So then if you have more surgery and more adhesions, it sometimes is a compounding problem. So I do want you to know about small and large bowel obstructions, because those can be kind of common. Okay, and then finally colorectal cancer. I think finally. Is there anything else I was supposed to talk about? The colorectal cancer is not that uncommon in the United States. Age matters. the younger, like a 55 and younger that's diagnosed with colorectal cancer is much more aggressive. The prognosis is much worse. If the patient is 65 and older, it's usually, if they're going in for their annual colonoscopies, they find a polyp, they're watching it, they can just remove it pretty easily, and sometimes they just need surgery. Sometimes they don't need radiation or chemo, especially if it's not beyond the colon. So if they catch it early enough, it's one of those cancers that's fairly easy to treat. Again, occult blood testing. So if you guaiac a stool, that's another indication that it could either be a bleeding polyp or a malignancy somewhere, anywhere throughout the GI tract. So that's why you do guaiacs, and then you can do proctoscopies, colonoscopies, sigmoidoscopies. It's just where they go up in with the camera and they can get a piece of what they think might be the malignancy. And you can get a CT scan, which will show a mass, but that just shows a mass. You don't know what kind of mass it is. You don't know if it's a malignancy. So anyways, there are different stages of colorectal cancer. Way more common in the United States than it is in Japan. And some of them, if it is significant enough that they do have to remove part of the colon, you can have a hemicolectomy, meaning part of the colon's removed, a total colectomy, meaning the entire colon is removed, and now the patient has an ileostomy. And sometimes they can remove part of the colon and then reanastomose the colon because it's very stretchy. You can stretch it quite a bit. And usually they'll do that before they'll make an ostomy. They'll avoid the ostomy, as much as possible. Okay, what else do I want you to know? We talked about polyps. Like I said, they can occur anywhere. They're not uncommon. Usually they're not malignant, but if they find one, they do watch it just to make sure that it doesn't become malignant, or they just usually remove it. Hemorrhoids and fistulas. Anal fistulas, fissures, those are just outpouching that goes to another area. Not super common. Usually they're treated with surgery. Hemorrhoids, very common, and often caused by straining, hard stools, things like that. So if you can keep somebody regular with nice soft stools, that oftentimes will prevent hemorrhoids. Pregnant women are at risk for hemorrhoids because the blood vessels engorge and they've got a baby sitting right in their pelvis. So those women, which I'm sure you'll talk about in OB, are high at risk for hemorrhoids. Cysts, pilonidal cysts, not super common. You don't have to know about that. Okay. All right. Yay. Okay, that's it. That's good. Now next week we'll do either renal or hepatic. I can't remember. So, okay, so that's it. And study that stuff, and we'll go over it more in class. Okay, see ya.